I'm here today with Rick Bukata, who's somewhat of an icon. He's certainly somebody that I had a lot of respect for a long, long time because of one thing, Rick. You were like the community physician savant. You were the guy who not only he did exactly what we all wanted to be able to do, and that is to work in a community setting because we didn't get into the academics, but we wanted to stay fresh and aware of the research and stay on the cutting edge. And you were the guy who did that. You know, and when you and Jerry were running the Rick and Jerry show, you had you kind of spoke for all of us in that. Jerry was kind of the academic egghead, and you were the guy who said, "Nah, that's not going to work in the real world." Tell me about that. How did that relationship work out?
Well, actually, it was frickin' frack, town versus gown, that's for sure.
Yep.
He was at UCLA. I was at San Gabriel Valley Medical Center, and for 25 years I was the director there, which is a single covered. Well, toward the end we had some PAs and NPs, but it was a single covered ER that was nearby, and so that was my place. And Jerry was at UCLA, where it's like a totally different world.
Really?
But they had every consultant known to man in the building, and I was lucky if I could get somebody to come down to the emergency department and help out. Jerry had a very skeptical view of the literature and had a great ability to assess the literature. I had no training in that at all, but I was of the view that it would be a fun thing to do, to search the literature on a monthly basis and see stuff that was out there for emergency medicine. And so we started Emergency Medical Abstracts in 1977. That was before you were born. I know.
No, I don't think so.
1977 we started, and we used a publication called Current Contents, which had the contents page of every journal that existed at that time. It is it's up to, it's got well over 2,000 journals that come out and it comes out every week, which is like, shoot me, here's another one. My sister reviews it, goes through, and she's a PA and goes through and finds every topic that relates to emergency medicine. We've gotten them all. I don't think we've missed any, honestly. And we put them in a database. We chose 30 to get the article and review and put it on the show. Actually, it was 40 in the beginning, and put it into a searchable database. And that's kind of where we went for a long, long time. Jury came along probably in the mid 80s someplace. We started doing audio not off the bat. We did it much later. But it got pretty cool because we could do in our searchable database, you could hear the sound clips of what we thought about a paper. We summarized the paper, added our editorial 2 cents. Jerry and I would often not necessarily agree on the paper, but
that's right.
That's the way it went. And for years, physicians would listen to 480 papers a year out of us. And I honestly believed that if you did that for a little while, you would really be on top of every issue in emergency medicine.
Yeah, that's right. That's exactly right. What you did for the practicing community clinician, it was absolutely invaluable. And nobody else for many years was doing anything remotely like that. And you've got a little more competition now, but and that's I was just talking to Judy Tentinelli about this, and that's the growth of the specialty. And I think all of us old guys really looked at that as the thing that helped us to be better docs. And being better docs, we got the respect of our colleagues upstairs because we were familiar with the literature on so many topics because of that. So. I can't tell you how much I thank you for what you've done.
You're very kind. We are allegedly men and women of science, and there was no systematic way to try to survey the emergency medicine literature since it was in all of the journals. It was in the internal medicine journal, peds journals, those kinds of journals. And so getting the 2 or 3 emergency medicine journals just wasn't going to cut it. Emergency medicine was a specialty in breath. We would do orthopedics. We would do the INDs. We would do the suturing. We would do the head trauma. All of those things were ours, and yet they were in all of the journals. And so you had to go and cull the journals looking for stuff that was specific for emergency medicine. And that's kind of what we did and still do.
That's crazy. That's
yeah, it is crazy.
But I'm again very very happy to have obviously gotten to know you over the years and to be a part of that from time to time. I want to talk to you about an area that you have gotten into recently, and that kind of reflects a pivot in emergency medicine, I think, and get your thoughts. And that is the use of, they don't like to use the term physician extenders, but that's physician assistants, physicians. We used to be called physician's assistants, but now they're physician assistants and nurse practitioners, or the advanced practice practitioners, MPPs. What?
Yeah, that's right. They call them APPs now. I don't like that term. I don't like to be called a advanced practice provider. I don't want to be a provider. You don't want to be a provider. We want to be clinicians. So every time I hear APP and I'm at a conference like that, I change it to APC, advanced practice clinician. So what success I'll have at that is probably kind of questionable. But you're right. The physician's assistants, they were called physician's assistants from the beginning. And then there was a move about 5 years ago to say, hey, let's change the name to physician associates, PA, physician associates. And I really like that. It seems like it was a more collaborative, collegial kind of concept rather than a vertically oriented concept. But that didn't go that didn't take off. I thought it should have, to tell you the truth. And then the nurse practitioners, for crying out loud, they're all doctors now, because they're really insisting that they get a DNP, a doctorate of nursing practice, which it takes forever to get. And I think, honestly, it's really going down the wrong track, but it's part of this endeavor to become autonomous practitioners, where you can set up your own clinic without a relationship with a physician, which is, I think, going on now in like 23 states.
Right. And I think that's not going to help improve the quality of care. It may bring costs down. It may, but I doubt it. And I don't think
it's got nothing to do with being a clinician. We had one of our NPs went, and really bright, very productive NP went to get this thing, and it's got nothing to do with being a better clinician. It's about maybe teaching people how to read the medical literature, and ultimately that may be a good thing to do. But the amount of time, work, and sweat that goes into this to get those initials after your name, and the return on that investment, I really think are questionable. To the extent that you don't see any more patients, or you don't see them any better, it's not quite sure why you should get a raise for being a DNP. Now, I basically am really strong supporters of nurse practitioners and PAs. They're a fact of life now, but I think that it's terrific that we have helpers in the emergency department, so that the doctors can see the patients that they need to see, and the PAs and NPs can see the others and help collegially, work in the emergency department. But this autonomous practice thing, I have a little problem with it. Obviously, the AMA is against it. And unfortunately, our PA colleagues are being dragged down this path because they think they're going to get left out of jobs if they don't have the ability to do autonomous practice. So, although initially they were against it, now they're going down that pathway as well.
Yeah. Tell me a little bit about the PA Bootcamp, because I don't want. We are going to have PAs and NPs here in this podcast, and I want to make sure that, and it's clear that as clinicians, we do support PAs and NPs in the emergency department doing quality work. I work beside PAs and NPs every night of that I'm there, and they're invaluable. Absolutely, their work is absolutely stellar. It's invaluable, and in the collaborative setting that you're talking about, where uh, the NP can say, "What do you think about this? What do you think about that?" Is really the best of the best. But I want to hear you talk a little bit about, give you an opportunity to plug your PA boot camp that you run.
Oh, come on, let's plug that thing. Uh, about 5 or 6 years ago, it was kind of like it was clear that PAs were being hired, and it struck me that they didn't have any kind of necessary formal education in being an emergency practitioner. 20 years ago, 30 years ago, we said you could not work in the emergency department unless you were board certified in emergency medicine. You could not learn on the job. Learning on the job was dangerous. But
Yeah.
30 years going forward, it is okay. You can learn on the job, and it is not dangerous. And it's like, what the heck happened there? So I was of the belief that we needed to create a really intensive course that would address probably 90% of what walked into the emergency department door. And so we created this boot camp course. And I think that we were successful because there was an unequivocal need for it. We had one course, Mark, that had 1,100 people go. 1,100. It was like, good Lord. It was like, how could you possibly uh, anticipate such a turnout? We've had courses that had 800. We had one last December that had 850 people. It's like they're hungry for this information.
Right.
And sure, many hospitals will do have some orientation programs and training programs for the PAs and NPs, but most it's kind of sink or swim, drop you in. And I can tell you a lot of them who are attending are recent graduates, and they have a great deal of apprehension about working in the emergency department. They want to work there, but they're afraid to work there.
Yeah, I had a nurse practitioner not too long ago who absolutely, she was bordering on panic as when she was seeing these cases, and it was exactly as you were saying. She felt that she had been thrown into the fire without adequate preparation, and it was just hopefully that she would survive the shift. And when I finally came to her and said, "No, you don't need to do it that way. I will actually shepherd you as I would teach a resident or a medical student at whatever level you come into. I'll help you with that." And it was like, wow, what a relief off her shoulders to be able to have somebody to bounce these cases off of. And it was clear that her education had not really prepared her to jump in and take over a case soup to nuts, as we are expecting our PAs to do. And this kind of training would be absolutely invaluable, and it should be required, to be perfectly honest.
Well, their training is primarily in primary care. That was
Right.
the genesis of these folks. And yeah, I think a lot of it kind of began in the military, where the concept of non-physicians being trained to assist the physicians, that was there, and that was obviously focused on potentially injuries and the like. But although that was the genesis, it's all about primary care, and I think that that's fine. But emergency medicine, there's some primary care in there. I mean, they learn about earaches when they go to be a primary care PA, but we have earaches in the emergency department too. So there are some overlapping circles of what they were trained, but there are big holes. And I think that, to be candid, I think emergency physicians are to blame in some of this, in that I think that they have a responsibility to really, really, really supervise and collaborate and work with these folks so that they can deliver the kind of care that we want them to deliver, the evidence-based care that is consistent with the literature. That's what we want, and they're only going to get it by their mentors in the department, or by outside sources. So we think that we're not the end all and be all. We think we're part of the idea of training these folks so that they can feel comfortable working in our departments. Because the other thing I personally believe is that you can't have these people seeing the minor cases and call that a career. They get 30 years. If just like we have 30 years, they're going to have 30 years in the emergency department. They're going to be able to see all the patients.
Yeah.
And that we need to evolve to that. Now, in some departments, they do see all the patients. In others, they're just kind of seeing the more minor cases, which, and there's the needle in the haystacks in those minor cases. They got to make sure they catch those. But I would think it would be a much more rewarding career if they could see the chest pain patients, the belly pain patients, and those kinds of patients as well.
Right. A lot of that has to do with the way we design and structure the emergency department. So many ERs will have fast track. It may be in actually another area, and it's completely away from the emergency physician, and so there's no interaction whatsoever in that. You call it the needle in the haystack. When the PA comes across a case where he's scratching his head and going, what is this exactly? Could this be something more serious because it just has a funny history to it, or is it just like all the others that I'm seeing all day long, the sore throats and the costochondritis and everything else? So I agree. I couldn't agree with you more. And the irony of that is that the PA is only going to see the minor cases in fast track, and then suddenly, when the PA is needed to come over to the main core or the main area, suddenly they have to see everybody, and we've given them the responsibility to do that, and I think that they have to have a more integrative approach and be commingled, so to speak, as you're saying, commingled with the attending physicians that are there.
I've seen emergency groups that have a very formal training program of their PAs and MPs where they have certain metrics that they meet with regards to the performance of supervised procedures and the like. And it's very formalized, and it may go a year or thereabouts as they integrate them into their department. And others, I think, are much more loosey-goosey. And top of that, it's made PAs and MPs have made it clear that sometimes when they're working, the physicians are kind of the view, well, you take care of your patients and I'll take care of mine, kind of thing.
Right.
They are not basically particularly open for consultation and the like. They somehow think that they're going to be more responsible for those cases when the fact is they're responsible for those cases anyway. They just don't know it.
They just don't know it.
And the other thing is this idea of, well, we're going to be signing charts at the end of the visit. Like, what the heck is that about? You've never seen the patient. You don't know whether the history and physical was
right.
well conducted. You don't know whether that diagnosis was based on a decent history and physical or not, or did they miss something? And it's like somehow your name on the chart says it's okay.
Right.
That was supervision. Come on.
Yeah. So we have to address that. We obviously have to increase the level of training of the PAs and NPs, but we also have to have a clearer understanding of the relationship in the emergency department. What is my function? If I sign that chart or my name goes on that chart, does that really mean that I supervise that? We click off these boxes. Yes, I personally supervised this, or no, I didn't. I looked at it, and we have to really clarify that relationship a whole lot better in order to really be true to our patients and to the public on the use of physician extenders.
It seems that when I talk to my colleagues, friends who go to the emergency department for various conditions, more and more they're getting seen by PAs almost exclusively. Belly pains where they're ordering CAT scans and the like. I'd still honestly, I'm old fashioned enough to say, geez, I'd like the doctor to stop in and say hello and, and work collaboratively rather than, well,
Yeah.
that's your case and you take care of that case kind of thing, and make the disposition and make sure you got it right kind of thing. When we started, we were we were older doctors when we started having PAs and NPs in the emergency department. We had a whole bunch of them, and I was kind of like among the oldest, and so we didn't feel too comfortable with this idea of them seeing the patients independently. So in the beginning, we saw every patient that they saw, but they did the charting. They just presented this package. We could go in there and very quickly uh, see them and feel comfortable that they were okay. And obviously, that's not the most efficient way to work, but it was nice that they all get to see the doctor at the end of the thing or somewhere in between, which I kind of thought was nice. And over time, that evolved to the point where it was clear that we didn't need to do that on every case. But in the beginning, it was the policy, so that we could feel comfortable with what they were doing. And in the same tone, our emergency department never had PAs or NPs, and so maybe patients who had been there would be surprised that they were going to be seen by somebody other than the doctor.
Yeah. I want to switch gears here a little bit. You and I have talked about this topic, and that is um, the opioid epidemic that's going on in the country right now. And as you know, I've gotten more involved in that here in the Baltimore area. I've at working with the largest methadone clinic in the country. At one point, the clinic I was with was seeing 3,000 methadone patients per day. That's just hard to get your mind around.
Yeah, sure is.
And I've gone on to work now with another group that is looking, and methadone has its place, and but it requires people to come in every single day to the clinic, which is just prohibitive for people who have jobs and lives and that sort of thing. And I'm now working with a group that is focusing on outpatient Suboxone therapy, and I've realized that the emergency department is the ideal place to identify, screen, and get people from addiction into outpatient treatment. The paradigm of a lot of people is that the only viable treatment is one, either abstinence, and we've shown that it only works in less than 10% overall. They might work 20, 30, 40% in the first 30 days, and that number just drops right off very rapidly at the 90, 120 day period. The only thing that really seems to have a long-standing positive outcome is people who are in what I would call supportive medically assisted treatment, which is Suboxone, something like that, buprenorphine. And I'm sure they're going to be coming up with other drugs and other ways to use it. But if people don't get into that treatment right away, if they're in withdrawal, they don't get into it right away, they just fall right back into into opiate use. And so you and I have talked about this, about the role that emergency physicians and hospitals have in encouraging the induction of patients into outpatient therapy. I want to hear your thoughts on that just a little bit.
Well, I agree with you 100%. If there are any physicians in the building who are going to be affected by the overdose situation, it's going to be the emergency physicians. And we are the ones who should stir the pot big time to get our hospital to, if they don't already exist, which I think in most cases don't, they need some outpatient follow-up where they can continue to get their treatment on a monthly basis. They can get some psychological support if it's available from psychiatric social workers or whatever kind of social workers would handle it. But there's no question that talk therapy just doesn't work, and
Yep.
and that Suboxone has decreased the mortality associated with opiates by 50%. It is grossly underutilized, and I don't know in the community how this is going to be integrated without involving the emergency department. They come to the emergency department. We can give them their first dose there if if they're not high or withdrawing then, and then but they need to go someplace else. And I think that they don't need to go to an addiction specialist. There's not enough of them around. Primary care doctors need to get involved. PAs and NPs need to be involved in the program as well, so that these folks can be given an opportunity to lead more normal lives, hold jobs, not have to go to a place where they drink this stuff in front of somebody every day. And these pills are where it's at and grossly underutilized. And, I have to be candid. I work at a very affluent hospital. I'm on their foundation. And the area around the hospital is very affluent, obviously, as well. And I'm wondering what that hospital and other hospitals like it would say if I were to go to them and say, listen, can we start a Suboxone program here? Because I think there's an image of these going to be these, we don't want those people here kind of thing,
Right, right. In Baltimore, it's called the NIMBY problem, not in my backyard. And the mayor
and yet,
of Baltimore wrote a piece just like that, not in my backyard, because we were trying to expand the locations that methadone could be used. And we know for fact that when you have 3,000 people coming in, there will be, where do you sell? Where do you fish? Where all the fish are, So where do the heroin dealers go? They go to all the people that are trying to get off of heroin. And so the whole idea of pushing this stuff out and to smaller and smaller and smaller clinics is a good idea, because it does diminish the diversion and crime issues. But you go to your average suburban hospital president and say, I'd like to start a program like that, and they will come back with, not in my backyard. I don't want to see those patients. It's get out of my ER. We should be recognizing that when these people come in that are obviously drug seeking. I mean, I write this on the chart, or, you're not supposed to write on the chart, but it appears that the patient is drug seeking. Well, for crying out loud, that's their problem. So why don't we try to address that problem instead of just booting the ER?
I was of the view, frankly, that all of this stuff on the front end that said, we're not going to give out as many pain pills. We're not going to be allowed to give out as many pain pills. It will be taken away from the discretion of the emergency physician how much pain medication is necessary for this condition. In fact, Trump is basically saying we're going to ratchet down on the production of this, so that we're going to create a shortage of this stuff as a way of dealing with it. I was very concerned, frankly, that patients with real pain were going to be, we were going to go from it was the pendulum was swinging from the oligoanalgesia of 10 years ago, where everybody was saying, you got to be more generous with this stuff.
Right.
And now it was going to swing in the other direction, and there are patients with genuine pain who are here, take these 3 Tylenol. I know it's Tylenol, but take it anyway, Good luck.
It's exactly what we experienced with prohibition. Exactly. Okay. And what will happen is it creates a black market. It's a balloon that you squeeze on one end and it comes out on the other end.
Exactly.
People, whether we created the addiction or whether they created the addiction from taking other people's meds, we could talk about the pathways to addiction all day, but the point of it is they're there. And so if all we do now is simply say, we're going to cut off your supply, that does not help the problem.
No.
And they end up just buying it off the street. And now that they're buying it from some knucklehead who we don't even know, that doesn't know what his supply, whether it's pure heroin or whether it's heroin and fentanyl, or whether it's pure fentanyl or it's a little carfentanil that's thrown in there just to juice it up a little bit.
Actually, absolutely. I agree that we basically have to look at both sides of the fence here. I don't like the idea of taking away from physicians the ability to use these drugs when they think they're necessary, in the amounts necessary, in the duration necessary. That does, I think generally in emergency department we're talking about 3 to 5 days of something, and
Right.
that's it. And we're not the bad guys. I had an arthroscopic surgery in October a year ago, and the guy gave me 50 Vicodin. I didn't need one.
My
It's like,
daughter, my daughter had some surgery postpartum, and the clinician, the surgeon, who's a colleague, handed me the prescription to go fill, and I didn't even look at it till I was getting ready to hand it to the pharmacist, and I looked at it just as it was started to leave my hand, and it was for 90 Dilaudid, 90. And I yanked it back, and I thought, what the heck? She might need 9, maybe, but
no, it's terrible. I think that it's very clear that, and people say, well, you gave them narcotics in the emergency department, and then that was the beginning, and then they got more and more. Well, who gave them the more and more and more? It wasn't us, for crying out loud. There are these jerks out there who just write them, and these are not even pill mill doctors. The pill mill doctors are the egregious ones.
right.
But this was a good friend of mine who gives me 50 Vicodin for a nothing operation.
Right. He wasn't trying to hurt you. He was just trying to make sure that you didn't bother him on weekends when he was
That's exactly right. Don't call. That was his way of saying, don't call.
Well, I had an orthopedic surgeon who's the head of the Maryland Society that told me that exact thing. It was just, it was 2 things. They told him, make sure that you adequately address their pain concerns. And the other was, don't call me on the weekend when I'm playing golf. I want to make sure.
Mark, we have talked about what's going on in Baltimore. And as a matter of fact, there was a physician who you knew who's been pretty involved in the Baltimore Suboxone programs. And I just got an article here. I found it last night. Baltimore citywide engagement of emergency departments to combat the opioid epidemic. This is in a big time journal. It's the American Journal of Public Health in the August issue. And it's a editorial describing what's going on there in the city of Baltimore. In some ways, you guys are exemplary in getting a jump on this and doing the Suboxone, because I got it. You have to admit, I think, that methadone is just kind of impractical.
Right. It only applies to people who largely, it's not to say that people in our clinic weren't employed, but an inordinate number of those patients were not employed. And the idea of having to go to a place, get your medicine, and then go to work was prohibitive for the patient. And they, as a result of that, the conscientious patient was trying to wean too quickly. And when they failed, which many times they did, there's so much shame and depression and self-loathing. It happens when people fail with this, that they wouldn't come back, and then it would be a long time until something terrible happened, and then they would finally come back. And I mean, we have to change that perception. We don't shame our diabetics when they fail to take their medication and they end up in out of control. We don't go in there and start shaming them about it. We just treat it and try to make sure that they know that they need to stay with their meds. Why is that not the case with somebody who became dependent on opiates, and why is it not just treated as a condition like anything else?
Well, I haven't taken the 8-hour Suboxone program, but I've talked to people who have, and one of the things that program apparently makes it very clear is this needs to be treated as an illness. These people's brains have been modified by the routine in taking in these drugs, and that it is a neurophysiological problem that we're dealing with here that needs these medications. And just like smoking is an addiction, this is an addiction. It's a biochemical process. It's not that they're willful bad people kind of thing. who choose to do this, and it's like they're hooked.
Yeah.
And that's why I kind of think there are people who have this problem who are in the affluent area that my hospital's in, who
More
come
than
in
you would
with,
realize. More than you would
yeah,
realize.
exactly, and they're going to come in suits. And I think that they need to come in, and it doesn't have to have a big sign on top that says, the opioid program of it
Yeah.
could be a
Right.
primary care. We have primary care doctors. We can get them their training on this. The hospital could, probably got an office or two available, and it doesn't have to be trumpeted to the world kind of thing. But I don't think we should be ashamed of it. And the
Yeah.
other thing is that there's going to be more and more and more money for this. I had read something that under the Obama allocations, which I guess are still in existence, the amount of money that was going to be directed toward this endeavor to try to stamp out the opioid epidemic was $3 billion. Well, that my understanding is now going to be $10 billion under Trump, and that's going to be so much money that people won't know what to do with it. There's not going to be the infrastructure to spend it. The idea of having clinics that will take any comer. They have a couple of them in Los Angeles now. There's two of them out in the San Fernando Valley where they doesn't matter whether you have money or not. They've been set up, but they're being funded by the state of California, and there's going to be lots of grants opportunities to get these things rolling.
Yeah.
And every nonprofit of any size has a whole wing that writes grants. And when
Right.
you write a grant, you got to write a grant for some reason. What
Yeah.
do you want the money for?
The
And
one thing that that I point out though is that a lot of times people are thinking that the only way to treat opiate substance abuse, opioid abuse is inpatient. These
oh God,
inpatient rehab units, and
no, no,
they are routinely $30,000+ per month. I mean, and I was talking to a patient the other day, and they were mentioning that their son had been in rehab, and I said, "Is he better?" He said, "Well, he's been in and out of rehab 17 times." And I said, "You didn't pay 17 times 30,000, did you?" He said, "They hawked the house, they emptied the 401k, and now they're broke, and now he's basically on the state." And I just, it's a
no.
catastrophe, financial catastrophe. And I think that if we really open up these outpatient clinics where we can keep people from withdrawing by keeping them on Suboxone, buprenorphine, then we can have a lot better results on a lot less expenditure going to a lot more people. That's the whole key.
I called the tertiary hospital in Pasadena here, and just out of curiosity, I called the drug program there, and I said, "Do you have an outpatient Suboxone program?" And she said, "No, we don't. This is the hospital.
Wow.
This is the big bucks hospital. This is where all the little old ladies from Pasadena go." And
Mhm.
they said they didn't. It's like the money was in inpatient.
Yeah.
Of course, the subset of people who can afford inpatient is going to be relatively small compared to the people who need it. But in any case, it seems to me that yes, it was $30,000, and the day the money was going to run out, there was a miraculous cure. Thank you, Jesus. You cured on day 29.
Yeah. Well, actually, the research shows that that's not the case. They come out and they do well for about 30 days, and then there's an incredibly steep um, failure rate. And I was talking to a guy representing one of the rehabs, and I asked him what his success rate, and he said it's 40 to 70%. And I said, "How did you get that number?" He said, "Well, we call patients." And I asked then, "How many of those patients that you discharged were you able to get in contact with?" Well, 50%. Okay, so let's cut those numbers in half. Between
Mhm.
40 and 70 now became 20 and 35. And I said, and at what point did you call him? 30 days. Did you call him at 60 or 90 or 120? And the research is very clear that there is a very steep failure rate after 30, 60, 90 days. And so we're back down into the 10s and 15% very quickly after a huge investment, a huge investment.
Well,
There's got to be a better way.
talk therapy doesn't work. Now you can put nice adjectives around that and kind of soften that up a bit, but this is a physiological problem that we're dealing with here. And why did you get into it? Well, you broke your hip, and you started taking too many of these things, and the next thing you know, you kind of liked it, and the next thing you know, you're hooked. It wasn't because you were, you had a bad child raising or something like that. It's kind of like this happens to good people. So
Right.
I think that we need to kind of get on the back end of this, and emergency physicians need to be the ones who are stirring the pot at their hospital to do this. Nobody else is going to do it. Who else is going to do it? The anesthesiologist, the
Right.
cardiologist. Nobody's going to do it. This is our task to run with this ball, and it is. I don't think it is particularly complicated. You just have to have the will to do it. There are some really nifty programs actually out of Baltimore where they have people who are ex-addicts who, when a patient is on opiates or other addictions is identified, these people speak to them in the emergency department and kind of give them the sense that it's going to be okay. I understand what you're going through. We have a program, those kinds of things. A friend of mine is
those are peer counselors.
Yeah. These are, this fella is a psychiatrist. He used to work for the University of Pennsylvania. Has had his name on a ton of papers relate to addiction. And now he's in private practice and treats all kinds of addictions. And he says by far the most easiest addiction to treat is opiate addiction.
Right. Right.
And and the answer is buprenorphine. That's the answer. Now, is it 100%? No. Is it substantially underused? Yes. Is there money out there going to be available for it? Yes. But if it's not in my backyard kind of thing, it doesn't matter.
Yeah.
How much money is out there?
Yeah. I only have a few more minutes with you. I want to hear your thoughts. You've been in this field a long time. Where do you think we're going in emergency medicine? My son-in-law just entered his internship in emergency medicine. What do you think it's going to look like in 15 or 20 or 30 years?
Well, that's kind of neat to have a family member in the same business. I think it's kind of that's a reflection to a certain degree on you and how he perceives you and what you do. I think in terms of what you choose to be the specialty that you go into. I'm not quite sure where it's going, to tell you the truth. It's like I had dinner 2 nights ago with Jillian Schmidt, who's on the ACEP board, and she said that the number of ER visits is stabilized and going down. I think there's all of these options. They have all of the CVS wants to take care of everybody at their places. There's telemedicine. There's going to be freestanding urgent care centers that are run by nurse practitioners who are autonomous. There's going to be a lot of other options. And, I think actually one of the other options was these freestanding ERs, which kind of began in Texas. And I thought, I didn't think much of them, to tell you the truth. I thought that this was kind of the equivalent of surgery centers, the ER doctor version of surgery centers. We're going to set up down the street from you. And if you can't handle these patients, we'll just skim off the ones that we kind of like to see. And so I thought there were some problems with that. Now, it's another thing to say there's a freestanding surgery center in the middle of Pippin. It's far away from the hospital, and that's why we put it there. But a lot of them that were owned or investor-owned were put right around hospitals down in Texas. You just looked at the map, and that's where they were. And their job was to extract from the hospital the people who had insurance. And so I don't know that that was our brightest hour, to tell you the truth. But you know, I think our doctors are really, really, really well trained now. I think a hell of a lot better than we were in terms of their capabilities. I think this integration of PAs and MPs is really, that's a phenomenon of the last 10 years, but it is still on the upswing substantially. I mean, we can't get enough of them, kind of thing. People always want to come to us because we do it when they want to have it done 24/7. Nobody else does that. So I don't think we need to worry about going out of business. I think we probably need to worry about how we're going to get paid. We just can't keep on ramping up the cost of healthcare. We're over $10,000 a person in this country, and Canada is at $6,000. So there's going to need to be some effort to rein that in. We're not the boogeyman about this, in that we're probably 4% of the national budget on this. But so I think that we're going to be around for a long time. I think pretty much in the mode we are. Your thoughts? What do you think?
Oh, that's a long conversation. I just talked to Judy Tintinelli about that. I personally think that we have an expanded role in front of us and I could spend a long time talking about the triage function that emergency physicians perform. And I think that it's likely or possible, let's put it that way, it's possible that the emergency department or something like that could be the portal to all healthcare. And I think that the inefficiencies of our system, where you go to your family doctor and he sends you to somebody else, or you get a lab, you have to go to a lab test, and they send you to a lab, they send you to an X-ray facility, and they say come back in 2 weeks and we'll read the film and we'll share the lab results with you. I think that's an efficiency that we can no longer afford, and I think that the likelihood is going to be that, or not likelihood, the opportunity is that people will come to something like the emergency department for all entry to healthcare, and that we would have the ability to get them to the right place efficiently with the least amount of expense. They talk about emergency departments being the most expensive point of care. I differ with that. I think that when we get people to the right place in a timely manner, we can become the most efficient use of care. So, and I think that, I'm a big proponent of telemedicine, and we could talk about that as well. I think there's a whole lot of medicine that could be handled without anybody going anywhere. And I think that the emergency physicians are perfectly poised to take over that role and to manage people in place. So I think that the opportunities for emergency physicians are large and expanding, and they go outside of the traditional ED. And
some of that has already happened in that we have these OBS units now that we may be staffing. We may be staffing the hospitalist division of the hospital. So we got that part. Urgent care clinics, we've got those too, and they're all part of this integrated system where we don't have to wait for a lot of test results to be done. And just as you say, that and in many ways that's already happening. So I think that, I do think that you're right. I just kind of took a lot of that kind of for granted. But yes, when you think about it, we are getting our fingers and toes into a lot of other allied areas that, and we are the source of all the admissions to the hospital for all practical purposes. I do think there are these issues which are probably bigger than us about trying to narrow variability and decelerate the spending that goes on in healthcare in the United States, which is really another topic.
Right. Well, Rick, thanks so much for your time and for your the history that you've added to our specialty, the color, the comic, all of that that is so associated with Rick Bukata, and the wisdom as well. So thank you very much, and I always enjoy talking to you and benefit so much by
You know,
our friendship.
yeah, you're very kind. I do appreciate the opportunity to talk with you. It seems that every time we don't talk very often, but every time we talk, it goes on for an hour and a half, kind of thing, because we seem to have so many things that in common and things that we want to talk about. And so I appreciate the opportunity to talk with you, Mark. And I'll see you at the
At
Scientific
ACE.
Assembly.
That's right.
Take care.
Okay, take care.